So I think we timed this pretty perfectly. I'm not sure if it was done intentionally with the U.S. Open just finishing up this weekend, but I think it's a great opportunity for us to talk about, golf performance, golf rehab, and how we utilize it with Takar therapy. So for those of you who don't know me, I'm Dennis Donovan. I'm a physical therapist down in the Palm Beach, Florida area. I see a lot of golfers. So this refers to, people that are just coming in to the office with injuries sustained from golfers, from golfing, people that I work with on golf performance, as well as, just patients who are being treated for something else, but they are avid golfers. And we will talk about, different ways we can, help improve their performance. All via the use of Winbacks to car therapy. So a brief overview of what I'm going to be talking about today. So we're going to start with what is golf physical therapy, and more importantly, I think what it is not. We're going to talk about some golf performance principles. I'm going to talk about the way I evaluate and assess golfers. I'm going to talk about the TPI level one screen, which is something I do with all my golfers. I'm going to talk about the most common golf related injuries that I see, as well as the most common golf swing deviations that I see coming into my office. And then the meat and potatoes of this presentation will be how I utilize the Takar therapy throughout a treatment continuum. So anyone who's heard me talk of any of these calls, they know I love using this from immediately post-op all the way through later phases of healing, through the chronic phase, and even now with the back four, using it with a little bit of a performance type of twist. So really excited to share that with you guys, and also talking about how I use it with movement. It's another thing I'm a big believer in, and using it with the exercise and using it in a way that's functional for the patient. The benefits that I see as a result of that. So, what is golf physical therapy? So, I think it's easier to start with what I am not. I am not a swing coach. I am not a biomechanics coach. I am not a golf pro. I am not a club fitter, and I am most definitely not a caddy. That being said, what I do or what I consider myself, trained in is the ways of making the body better able to meet the demands of the golf swing. So we do this through assessing golfers' length, range of motion, strength, neuromuscular control as it relates to the individual body parts, and what those body parts are asked to do during the golf swing. So, and this analysis is going to go from head to toe. I really start at the ankle and we'll go all the way up to the cervical spine, making sure that these players can attain the desired range of motion. They have the strength to produce power in those ranges, and the neuromuscular control to, sequence kind of what they're doing, as well as identifying swing deviations that may be present based on the bodily limitations that these golfers are coming into the office with. So understanding how a range of motion deficit at one joint can affect joints, above or below it, and what, swing deviations we may see as a result of those limitations. So a couple of golf performance principles. Whoops, sorry. A couple of golf performance principles. So stability versus mobility. During the golf swing, our body is really an alternating pattern of stable and mobile segments. So it's important to understand golfers don't train the way other athletes do. They need to have mobility to move their bodies to extreme ranges of motion, and also have the muscular strength and control to produce power in the transverse plane through these ranges. Another principle is neuromuscular control, or what golfers refer to as separation. So this is just being able to move mobile segments of the body around stable ones. From there, sequencing is another big part of the golf swing. So the kinematic sequence, for the backswing, the swing will always start with the lower body, followed by the thorax, followed by the arms, and followed by the club. and then the deceleration sequence happens in the exact opposite order. So the idea is that each body segment builds on the previous segment in order to increase power production. Um, Now, this is how I evaluate golfers. So the first five things I look at, and it's funny because people will typically say when they come in to see me for a golf performance evaluation, they say, "Oh, should I bring my clubs?" And I say, "No, actually, for the first session, I don't want you to bring any of your clubs. What I want to do is take a look at you from a head to toe perspective, see how each individual body segment moves, and then from there we get into, swinging and stuff like that. But I'll always start with the TPI level 1 screen. It's a 16 item full body assessment for golf related strength and mobility. And from there, I will use a Kinotech, which is a LiDAR camera. I have a perforated playlist of movements that I will screen all my golfers for. What I really like about that is the camera has the ability to pick out where in the range of motion compensatory movement may set in. And I find that super useful for diagnosing and treatment of people with deficits. From there, I like to look at thoracic spine power testing. I look at leg press power testing. So we'll look at right leg versus left leg, backswing versus downswing. What we're really looking for there is there a large asymmetry? Obviously, when we have a large asymmetry, right versus left, puts the athlete at a risk of injury. So something I like to address from the beginning. Lastly, I like to take a look at their ability to dissociate their trunk from their pelvis. So, two things I want to see, right? One is, can they move their body or their trunk around a stable pelvis? And can they move their pelvis around a stable trunk? These are two very important things for golfers to be able to do. The picture I have here is me working on a golfer. We're trying to assess his trunk rotation. And what you see me doing there is applying a little bit of stability force to his pelvis, which in this case allowed for him to increase his range of motion. So that tells me that the range of motion deficit, we first observed is more of a stability problem or a separation problem, hard for him to rotate his trunk around his stable hips. When I give him that stable support, he is better able to move his trunk. So this is typically where I start with my golfers. All right. And now the Titleist TPI level 1 screen. So again, like we spoke about, this is the idea is that the body is an alternating pattern of stable and mobile segments. So these 16 tests are designed to assess our core control, our ability for lower body dissociation, upper body dissociation, the ability to maintain posture, and then some tests for setting and releasing the club. So starting with the foot's going to be stable through most of the golf swing, whereas the ankle will be mobile. Moving up from there, the knee is going to be stable compared to the hip that's mobile. Pelvis, sacrum, lumbar spine, going to be more stable, whereas the thoracic spine, we need to be more mobile to rotate around that. Scapulothoracic joint is going to be more of a stable joint throughout the golf swing, whereas the glenohumeral joint going to be more mobile. Elbow is going to be more of a stable joint through the golf swing. It's something I see a lot of is, amateur golfers coming into my office with flailing elbows. So this is something that I also try and educate all my patients on. Elbow range of motion should be more limited throughout the golf swing. The wrist is a mobile segment and the cervical spine is a stable one. So these are the TPI screens. I'm just going to talk through them very quickly. So the first thing I look for, the first test is the setup posture. So what we're looking for here is we put the patient in a 5-iron posture and just look at what the position of the spine is at setup. So are they more kyphotic, what we call a C posture, or do they have more of an S posture, which would be a little bit more, lordotic through the lumbar spine? Pelvic tilt test. So what I want to see is, are they able to tilt their pelvis anteriorly and posteriorly, but from a functional golf position, so with a slight hinge at the waist. We want to look at their pelvic rotation around a stable trunk, their torso rotation around a stable pelvis. We look at the overhead deep squat. Something I like to add to this screen is having the patient do it on force plates. And what I find that's really benefit for is it'll tell me if they are loading one side more than the other. Also, that would maybe be a predictor for injury risk. Toe touch test, which is an assessment of hamstring length, 90-90 shoulder external rotation, single leg balance, lat length test, lower quarter rotation, which is the picture you guys can see here on the right. So that's really closed chain hip internal and external rotation. Something that I'm going to talk a lot about is improving hip mobility, because as we get into this, you guys will start to see just how important the golfer's hip mobility is to not only the swing sequence and kinematics, but also for injury prevention. Seated trunk rotation, way of looking at the thoracic rotation around a stable lumbar spine, single leg bridge, cervical rotation, forearm rotation, pronation and supination, as well as wrist hinging, ulnar radial deviation, and then lastly, wrist flexion and extension. So these are the most common golf injuries I see. For the sake of time tonight, I've highlighted in red the ones that I'm really going to spend a lot of time talking about. So first is golfers or tennis elbow. Many novice golfers will actually wind up with tennis elbow due to faulty swing mechanics. I have some data that I got from the Titleist Performance Institute we'll talk about in a little bit, but there's some research that says tennis elbow actually outnumbers golfer's elbow in amateur golfers by as much as 5-1. So we're going to talk a little bit about that. We're going to talk about low back pain and hip range of motion deficits and how there is a correlation between the two. So what I see so much of is right-handed golfers with right-sided low back pain, left-handed golfers with left-sided low back pain. We're going to talk about how addressing hip mobility and closed chain hip rotation can help with that. And typically what we're going to see a lot with these patients is that their lead hip has an internal rotation deficit. So what I'll typically see is that especially on the follow through, they need to rotate in the closed chain, that pelvis over the hip, to really get a good follow through. If that hip internal rotation is lacking, they're going to put excessive rotation through the lumbar spine. Hence why we will wind up with the right-handed golfer with the right-sided low back pain. I also see a lot of core muscle injuries and thoracic rotation deficits. I have some good videos I'd like to share with you about how I use the WinBack to address those. I also see a lot of rotator cuff pathology, impingement type of symptoms, and some upper lower cross syndromes. This I typically see with my, weekend warrior golfers who spend, Monday through Friday doing mostly desk work, and then they want to play 54 holes over the weekend. So have to do a lot of postural, modifications with them, but it is something that I see, quite a bit of. So most common injury in pros is typically overuse, whereas the most common injury in amateurs is usually mechanical issues. We don't think of golf as a contact sport, but some of the data that TPI has collected has suggested that 50% of golfers throughout their career will develop an injury that will cause them to miss greater than 3 weeks. And as much as 1/3 of touring pros at any given time are playing injured. So most common reasons for injury are typically poor body mechanics, poor swing mechanics, excessive practice / overuse, program and exercise routine, nutrition, dehydration, and improper club fitting. I highlighted in red the ones that are really in my wheelhouse as a golf, more of a golf physical therapist to address. As far as the real, nitty gritty mechanics of the swing, and definitely club fitting, that is more the work of your golf pro, your club fitter. So most common injuries, most common swing deviations I see now. This is important because these are directly correlated to the most common injuries I see. So the first is a reverse spine angle. So really nice picture I have up here in the top right there. You can see for this right-handed golfer, he is at the top of his backswing in a left laterally flexed position. Um, and basically, this swing characteristic makes it difficult for the golfer to initiate the downswing with that proper sequencing that we were talking about before. Typically, these golfers are upper body dominant and they don't get their legs involved much. But this swing deviation has been considered the number one cause of low back pain in amateur golfers. And what do you know? Also, usually is associated with a lead hip internal rotation deficit. So these golfers will also struggle with separation and core control as well. Um, the next is S posture. So that's that, increase in lumbar extension at setup. I see this with some of my lower crossed patients, but when we get into that extended position for the lumbar spine, it makes, rotation a little bit more challenging. The third deviation is really a group of deviations, and this refers to loss of posture. So basically, this just means we're losing the angles we set up, we're losing the angles of setup during our backswing or our downswing. So picture I have on the bottom right there is a really great example of what we call flat shoulder plane. So you can see on the left side, the golfer is kind of standing up out of his backswing, whereas on the right side, that golfer kind of maintains that plane he establishes at setup. Shoulders are pointing down towards where he is going to be swinging that club through. Um, Early extension occurs when the hips or spine of a golfer start to, move forward or extend too quickly, causing the golfer to sometimes stand up during their downswing. And a sway and a slide. So sway is more of a backward weight shift outside of the hips during the backswing. So what we see is, from a head-on view, that these golfers will slide. A right-handed golfer will sway to the right during his backswing. This is usually the result of a trail hip internal rotation deficit, whereas the slide is more of a downswing deviation where they kind of get this dramatic weight shift forward. So a left weight shift for a right-handed golfer also can be the result of a lead hip internal rotation deficit. So we're going to talk about golfer's tennis elbow to start. So like I said before, golfer's elbow can outweigh tennis elbow. I'm sorry, tennis elbow can outweigh golfer's elbow as high as 5-1 in amateur golfers, with the lead arm being the more likely issue. One of my absolute favorite uses of Takar therapy is early loading for tendon injuries. I find that it allows for really improved pain-free isometric loading. We can start, creating healing, getting those, tendon fibers to align through a gentle contractile load. And the Tekar is awesome, awesome, awesome for doing that. So typically what I'll do is I'll start with a capacitive current, about 20%, just working over the extensor mass, trying to calm down irritation, saturate superficial pain receptor nerves. I'll do, depending on the acuteness, I will toggle that for, more acute. I will be on the lower end of the intensity, but for more chronic issues, I will work a little bit higher. From there, I'll transition to the resistive current with the high 10. So again, if dealing with more of an acute injury, I'll use the high 10s at 25 hertz. Whereas if I'm dealing with something more chronic, I'm going to use 2 hertz. And then from there, again, all with the bracelets on my hand, I will actually start gentle isometrics against my resistance. So here I have a video of me just doing a little bit of gentle soft tissue work for the extensor mass, working at 40% heat. Again, this is just more of my super, earlier on soft tissue work following use of the capacitive current. And then on the next slide, I have me doing a little bit of some isometric work here. So I have, one hand, 2 bracelets on, one hand over the extensor mass insertion, the other on the wrist. And you can see this gentleman is kind of pushing into my hand. I'm cueing him sub maximum effort. I believe this was one of the first times we did it, so I didn't need him to give me a whole lot, but I just wanted a concentration of that current in the tissue that was contracting. So anyone who's heard me talk, on any of these calls has heard me talk about, how much I love, doing stuff actively because it really improves the specificity of the treatment. And, we'll talk a little bit more about some other ways that we can do that. But, placing a contractile load on pathologic tissue is a really great way to, improve the accuracy of what we're doing. This next video here is doing a little bit of pronation and supination work. So I'm utilizing the ground handle there. And here I actually wanted to put a little bit of a contractile stimulus through that handle. So I pause it here. I have the high EMS going now at 50%, which sounds like a lot, but for this gentleman, it was very comfortable. It's one of my favorite things about the back four and the high EMS setting is that this, EMS can be so comfortable and they can do it while they are exercising. I have the resistive current at 60%. So, on the upper end of that and the high tens at 5 hertz. And, utilizing this flywheel here really to promote, concentric to eccentric control, having him work throughout that entire range. Put that one more time so you guys can see. So I have the applicator kind of over the tricep, so that current is being dispersed through the entire upper extremity. So again, love utilizing the flywheel for this. The slow, heavy resistance really helps, I think, with coordinating movement patterns. So it's something I'll do earlier on. This video I love here because we're doing a little bit of a downswing drill. Now, this gentleman was having a little bit of medial elbow pain, not really related to tendinous, injury or anything like that. But what I did is I have the, again, ground handle, and I have a adhesive applicator over his scapular area. So what was really cool about this, and I'll play the video one more time, is that, he wasn't feeling any heat at his scapula, wasn't really feeling any heat at his hand, but where he was getting a concentration of current was right through that medial, compartment of his elbow, which is exactly where we wanted it to go. And during the downswing, that's going to take some of the stress, of the swing. So it goes back to what we were talking about before, that when we alter the resistance of the target tissue, we're using the Takar therapy, we really improve the accuracy. We get that concentration of current exactly where we want it to go. And we can do this through exercise, contraction, dry needling, cupping, instrumented assisted stuff, and just movement in general.
Dennis, can you put your arrow on where you had the ground?
Yes, sure, absolutely. So the ground in this, it's actually on the posterior aspect of his right, upper thorax. So you can't really see from the video, but you can kind of see where this wire comes in here, and I have the adhesive up on his right shoulder blade, basically.
Thank you.
Of course, yeah. So now let's get into low back pain. I'd be shocked if there wasn't a clinician on this call who didn't have someone walk into their office in the last, week or two, who didn't have low back pain. It's something we see, almost daily, definitely weekly, I think. As it relates to golf, again, lead hip internal rotation is a huge predictor of low back pain in golfers. We talked about the swing deviations that we might expect these golfers to have if they are coming in with low back pain. But how do we address it? Got to improve neuromuscular control of the core, got to improve the pelvic trunk dissociation, and have to improve hip mobility. So first thing we do is calm it down. Similarly to the way I address the, the extensor mass, lateral epicondylalgia injuries, I will start with the capacitive current. I like to run this in dynamic, so I'm toggling depths. I find it super beneficial to just address, what's slightly below or slightly above the target tissue I'm looking to get at. And then again, just trying to calm down superficial, muscular soft tissue, as well as saturate some of those pain receptor nerves, get them moving with a little less discomfort is a real great start. Intensity, obviously, like I said, will depend on acuteness. For more chronic, I'll work it, 40 to 50% in the boost on the back for about 5 to 8 minutes. From there, I transition to a more active setup. So you can see here, this video was filmed on the back three. So I'm using the splitter. I have two applicators over each of the thighs with the ground over the lumbosacral junction. Now, this is great because I'm getting a current traveling through both hips at the same time. We start very gentle with, pelvic tilting, TA activation, supine marching, your whole lumbo-pelvic stabilization routine. And then we progress to some, slightly harder stuff before we transition them off the table. So here in this video, I have this woman doing a little bit of banded bridges just to increase some gluteal activation. You can see here I'm working at 40% heat, dynamic with the resistive, so toggling between RET and RET plus. Another thing I love, love, love to carve for, like we were talking about, early phase isometric loading. So here, this first video is a gentleman who is having a little bit of, kind of mid-back rotation pain. So what we did was I have one applicator, I'll pause here, kind of on the cervical thoracic junction in this area. The other one over the lumbosacral junction, more, distal. I have that current traveling through the spinal column, really trying to get like those multifidi, those deep, rotator, anti-rotator muscles. And all I'm cueing the patient to do is gently rotate to his right and hold for 10 seconds. So this is someone who was having pain through rotational movements. And what we did was we started, close to neutral. He's a little bit to the right. And then we changed this. We progressed to greater ranges of rotation, isometrically loading it through each phase while running the Takar, and then eventually transitioned into a more smooth and fluid rotation, which dramatically helped decrease this patient's rotational pain. So 50% heat, I'm running it at the same time as the high tens. Most of what I do is this way with the resistive current running at the high tens at the same time. Find it great for just toggling to that most the deepest current you're going to getting all the resistive tissue as well as the bone, tendon, ligament, and cartilage. Next video I have here is one of my favorite exercises. So basically what I'm asking the patient to do here, I'll pause it as we turn to the back, right there, is he is holding a kettlebell in the contralateral arm while he is engaging the glute in an abduction isometric on the opposite side. Awesome way to engage those posterior oblique slings, which I find super, super important for golfers. A lot of golf, trainers and golf trainers will exercise their clients this way. Has to do with really how the golfer has to move throughout the golf swing and the demands that the golf swing puts on the body. So going back to what we were talking about, as far as the stable and mobile segments, right? We're getting a really good contraction here in the scapular thoracic joint, getting some stabilization there, while he is also engaging the gluteal muscles on the other side. So really the goal of this is core control, and he's a little tilted for where I like, but you see here, have the high EMS going. Again, looking to increase contractility. So let me back that up again. I have right here is the applicator right over that SI lumbosacral junction. The ground is over the just distal to the gluteal fold. This is a gentleman who is having more SI joint pain. So again, really like this exercise for creating some lumbopelvic stability. Getting the Takar running at the same time as we're doing it really helped decrease his discomfort with that movement. We then progress to more higher level rotational work, but that's the idea there. So again, one of my favorite exercises for golfers, just because I find there's a lot of functional carryover to the co-contractions that golfers need to be able to fire for sequencing during their swings. Oops. All right. So these are just two really quick videos. I know we talked about, rotating the pelvis around a stable trunk, rotating a trunk around the stable pelvis. These are two things I do with all my golfers. Not really to car related, but in this video, I'm asking this gentleman to rotate his pelvis around a stable trunk. He is trying to trace that line. We have a trunk sensor on him, which is going to tell us just how well he does that, how well he is able to move his pelvis in all directions. And where he starts to compensate by using his trunk. This video, I have a golfer trying to do the exact opposite. So he sees the video is not great, and I apologize for that, but he sees two plus signs on that screen, a purple one for his pelvis and a red one for his trunk. I'm asking him to keep his pelvis steady there and rotate his trunk as far as he can, right and left, allowing that red dot to move around a stable pelvis. Love utilizing the biofeedback here to help the patient strengthen that mind body connection. So now addressing hip mobility. So golfers, a lot of their hip mobility comes in the closed chain, but that doesn't mean I won't look at it in open chain. So I'm in this first video here utilizing a very similar setup to that woman I had on the table with the bridges. The only difference is now I'm using it on the back four. So let me pause this here. So I have two applicators on the thigh with the ground over the low back. This is some now, benefit of doing it on the back four compared to the back three is I have two active channels producing the exact same power now. So it's a much more, concentration of heat there, which I find really great. And I'm just having him do more of this as a warm up, trying to get the hips moving. Again, 50% boost for the resistive current, working at a pretty high level of heat, also in the high tens at 2 hertz. One more time. Again, just working on that hip internal to external rotation, right versus left. Now, the next one here, I have a little bit of it's same setup from a tech car standpoint, but I have him working on a little bit of closed chain hip hip external rotation with the cue to allow his knee to try and come past the hip, so he gets a little bit of that closed chain internal rotation as well. Same parameters as in the previous video, 50% heat with the boost, really trying to do what we can to loosen up the those hips. And he's just doing a little bit of that with resistance. I find this setup to be, slightly more functional for the golfer. Might be a little bit more flexion than what a golfer needs, or than what a golfer uses for that rotation. But nonetheless, really like it for that reason. Is the golfers do rotate their hips around the pelvis from a slightly flexed position. Seems like I've got a video error here. Anyway, so talking about core muscle injuries and trunk rotation deficits, golfers need to have a strong core as well as the necessary thoracic spine rotation to meet the demands of the golf swing. Typically, lumbar spine only really has about 15 degrees of rotation, not really biomechanically designed for that, whereas the thoracic spine has closer to that 45. So during rotation, the external obliques, rectus abdominis, multifidi will contract contralaterally, whereas the lats, transverse abdominis, internal obliques will contract ipsilaterally. I'm not sure why this video isn't playing, but basically it was a video of me using that LiDAR camera to do a little bit of rotational testing. Again, the thing I like best about that is it'll show me where in the range of motion the golfer starts to compensate. So I'm sorry that video isn't playing for you guys. All right. So these are two rotational exercises I do with golfers. So starting in a quadruped position, again, utilizing a load here just to get a little bit of the thoracic rotation. Now, I have these adhesives on either side of his core. So one on the right side, one on the left side, really trying to get, those oblique muscles firing. Another thing that I'd just like to point out, because you guys saw in the previous video how I strap down those pads. Whenever I'm doing something active, I don't want those pads moving. So I'm constantly using straps. I will even tape them down. I really don't want them sliding, especially with rotational work. When I start challenging guys to produce more power, really want those pads fixed. So I encourage you, if you are doing something active, try it out, definitely, but don't be afraid to tape down the pads, just to prevent any slipping or sliding. So from the quadruped rotation, we may progress into something a little harder. This is like a loaded book opener exercise too. I really like. Pad position is the exact same as I described before. Really focusing on trying to increase that oblique activation, send fresh oxygenated blood and that Teccar current to that tissue. So, as far as when we get into golf performance, this is something I've been utilizing more frequently since I got the back four a couple months ago, is the high EMS to try and improve contractility and try and improve power output essentially. So later phases of performance, I like to incorporate this in. Not only does it decrease the pain with the movement, but what we had found prior to the utilization of the high EMS was that 10 minutes of Takar could increase contractility by like about 10%. So the added benefit of that high EMS, though we haven't tested with our EMGs yet, we can assume that that's going to have a positive benefit there. So you can see here, I have those pads positioned the exact same way they were in the previous videos, with one on the right side of the core, one on the left side. See, he's going through that rotational exercise, and I'm going to pause here because again, working at a high level of heat with the boost at around 50%, the high 10s at 2 hertz, and then that high EMS again with the 40%, really trying to help assist those oblique muscles to fire, in a more efficient way during the rotation. So it's another reason why I love using the back four with exercise. So just a couple of key things before I wrap up here. Highlights I really wanted to make clear was that the Teccar can be used across the treatment continuum. So I tried to highlight how I can use it from more acute early tendon loading all the way to later phases of healing, chronic cases, and even performance, like you guys can see in this video. The active movement, exercise, contraction is a great way to improve the treatment accuracy. And when working with golfers, always take a look at the hip mobility. It's so important, I find, and more people than not have some sort of hip rotation deficit. Takar is a great way to aid in improving muscular length as well as capsular mobility. These are my references, and any